Thank you for your patience. So I'd like to welcome and thank our public comment speakers for addressing the committee today. All of the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For our speakers today, we have a limited public comment period, and I apologize, we have been behind schedule. In order to make it through all of the listed speakers, it's extremely important each speaker limits his, her, or their remarks to 3 minutes. We'll be displaying a timer on the screen so you know how much time you do have left. As a gentle reminder, our committee always appreciates diverse viewpoints that are respectful in nature and issue focused. And we want to thank again our public commenters, and we look forward to your comments. So today's first public comment speaker is Ms. Elizabeth Ditz. Ms. Ditz?
Hello.
There we go. Thank you.
I would like to thank the committee members for their tireless work over the last 2 years and the effort you have made to make the decision factors public and transparent. I am speaking as myself and as an active member of a Facebook group, Vaccine Talk, that has almost 79,000 members worldwide. Some of the Vaccine Talk members are physicians, virologists, and other professions involved in vaccine safety. These experts volunteer their time to educate other members. I've also learned from people not in the Vaccine Talk group, such as Kimberly Manning, MD, whose stories from her Grady community have taught me so much about meeting people where they are. Based on the questions posed to Vaccine Talk, I would say that the primary response to all COVID vaccines is anxiety. Many are anxious about the safety and efficacy of the available vaccines. Others are anxious about when they will be able to get them vaccines for their children. For those anxious about vaccine safety, those anxieties can sometimes be relieved. One noticeable feature is the general public, as represented by the members of Vaccine Talk, don't understand or undervalue that all vaccinations have for true public health. There's an overemphasis on the direct vaccine effects. It is, in my view, the U.S. government overall has had less than optimal messaging about the safety and value of vaccinations to prevent COVID-19 and other diseases. The VSafe program has been generating a vast amount of data, but little has been shared in a timely manner. Likewise, data from the Vaccine Safety Data Link and rapid cycle analysis is almost invisible to the general public. Going forward in public health planning, crafting a more robust and effective public information platform would reduce vaccine hesitancy. As you know, there's a large literature on how to address vaccine hesitancy. I hope that government can recruit and train community level experts. Also, having a general presentation on VSafe each meeting would not be a waste of time. Thank you very much.
Thank you very much for your comment. Next speaker is Dorit Rice.
Hello, can you hear me?
We can, thank you.
Thank you. So first of all, thank you committee for giving me a chance to comment again. My name is Dorit Rice. I'm a professor of law at UC Hastings College of the Law. And I want to raise 3 issues. First, I want to reiterate what Ms. Ditz said and thank the committee for its hard and transparent work holding this meeting continuously over the past year. And I hope the process continues to be respected, because keeping open expert advisory committee meetings, as happened, for example, for the change related to 16 to 17-year-old booster, can undermine trust and legitimacy, especially when there is uncertainty, as here, we really need the committee's input and the transparency helps. Second, as a process point, I realize that in an emergency meeting, there are things you cannot do. But although ACIP is rightly, uniquely able to recommend vaccines, your recommendations need to be explained and communicated to the public and the immunization community by organizations on the ground. These groups need to have an idea about what's coming. I realize it takes time, but it sounds like the vast committee knew of this at least since December 6th, and the meeting slides were not up until noon ET to Eastern time today. It would be appropriate to put out information for groups that would have to address this beforehand, as early as you can, and as early as you provide it to committee member, at least in some form, at least short shortly, because communication takes work as well. And I will add that although I do think you should generally consider moving to well-designed written comments instead of oral, here with an emergency meeting, that's probably impractical, but we need to realize that when people are not afraid of commenting slots in the morning of, the value of public comments would be limited. Finally, I appreciate your caution in recommending. I would like to encourage the committee to remember that there are groups for whom mRNA vaccines may be a higher risk than the risk of J&J, or as pointed out by members that will not use mRNA vaccine. Your language in the slides we've seen before talks about may be offered mRNA vaccine, and I would urge the committee to consider moving to a should be offered mRNA vaccine where people cannot safely take the mRNA vaccine, should be offered the J&J vaccine, when people cannot safely take the mRNA vaccine or will not take them, to increase vaccinations rates generally. Thank you very much for your time.
Thank you for your public comment. Next, Ms. Shoshana Fishbein.
Hello, can you hear me okay?
We can, please go ahead.
Thank you. Hello, my name is Shoshana Fishbein and I represent Families Fighting Flu. Thank you for your time today. I first want to thank ACIP for all their hard work during this pandemic and beyond for improving recommendations for adult and childhood vaccines. As you make this difficult decision today, Families Fighting Flu, a national flu vaccination and education organization, reminds you of the importance of preventing COVID because we're entering a season where flu and COVID-19 are co-circulating. We need to be clear in our messaging that both vaccines are necessary to prevent overwhelming our healthcare systems. We know that there are often concerns about side effects from vaccines, and we've heard many of these in the case of flu vaccination. However, in the context of today, we also need to keep in mind that vaccine equity is an issue, and other countries look to the U.S. for guidance on vaccines and donations, especially in the case of COVID-19. Viruses don't know geographic boundaries, and the U.S. is a leader in vaccination. The recommendations you make today for all vaccines and flu and COVID-19 do matter, and we appreciate all of your hard work. Thank you.
Thank you for your comment. Dr. Robert Edmonds.
Dear committee, today I will again speak about tinnitus and the Johnson & Johnson or Janssen vaccine. COVID-19's vaccine, including Janssen's vaccine, have saved many lives. Identification, though, of low-frequency adverse events connected to vaccination are important, not always to discourage vaccination, but to encourage patient education to seek timely care, and for provider education to apply the appropriate treatment should these low-frequency events occur. Peer-reviewed case studies of tinnitus following vaccination potentially suggest a small window of time for treatment of tinnitus after onset utilizing corticosteroids. After this limited window, though, management is often the only remaining option available. Janssen has at prior meetings presented data that indicates from COVE 3001 an imbalance of 15v4 that has a p-value of 0.0096, and a combined imbalance from all phase 3 trials of 24 versus 9 that has a p-value of 0.007. The European Medicines Agency recognizes this link after reviewing post-authorization reports. I have asked officials at the CDC and FDA whether they have reached out to the EMA and what made them conclude there is still not sufficient evidence that there is not a link after reviewing the EMA's analysis. I have not gotten a response. Many theories have been floated as to the causal mechanism in peer-reviewed literature and potentially includes a version of microclotting. No active follow-up is known to have occurred, so for now, these are just ideas that have been postulated. Follow-up is important because it may not just have implications just for Janssen potentially. AstraZeneca has an imbalance with tinnitus, albeit less statistically significant. And while Janssen reported an imbalance, the trial data, to Janssen's credit, did capture a measure of the tinnitus background. 9 cases were observed in the nearly 37,000 combined placebo groups with Janssen data. 0 cases were observed within, again, the nearly 37,000 combined placebos of the mRNA's trials to the best of public's knowledge, thus leading to a question, could the mRNA trials potentially have been insensitive to measuring a signal with tinnitus? I never imagined this time last year I would be speaking to a committee like this. I only bring this issue forward forward, again, because this isn't a little ringing in all cases. After developing tinnitus myself and dealing with an amplitude that rang at months 24/7 above a truck radio while driving, this is a place I don't want others to find themselves in. People very often don't know to seek care, and when they do, doctors often don't know what to do. Please follow up with us. Please learn from us. Those with this adverse event include a prior ACIP member. Again, I agree, the public should get vaccinated against COVID. This is simply about providing information about what to do in these rare instances. Thank you for your time.
Thank you for your comment. Next, we have Ms. Claire Hannon.
Good afternoon. I'm Claire Hannon, Executive Director of the Association of Immunization Managers, representing state, territorial, and urban area immunization program managers. Thank you to the Advisory Committee for convening this unscheduled meeting to provide guidance on the use of the Janssen COVID vaccine. It is critical that our nation's immunization experts meet regularly to review and monitor vaccine safety data and in a transparent and open forum. The J&J vaccine plays a unique role in the COVID vaccination response. Frequent populations for use are with individuals experiencing homelessness, residents in corrections facilities, and patients being discharged from hospitals. The one-dose completion also provides an accessible option for those completing vaccination for travel or employment. Maintaining vaccine options, as well as providing transparent safety data and expert advice, are important to support confidence in vaccines. So thank you for holding this transparent and open meeting. I also want to take this opportunity to acknowledge the one-year anniversary of the launch of the COVID vaccine campaign. 486 million doses administered with over 200 million people fully vaccinated. This is absolutely incredible given where we were just 1 year ago. Sadly, more than 800,000 Americans have lost their life due to COVID. But a Commonwealth Fund analysis estimates that the COVID vaccination program in the United States has prevented over 1,087,000 deaths and over 10 million hospitalizations. Finally, I want to draw attention to a current challenge affecting COVID vaccine program management. COVID vaccine thresholds limit the amount of vaccine that awardees can order and have been put in place to manage inventory and reduce waste. Although vaccine supply is plentiful in the U.S., awardees are not able to order vaccine above their threshold amount unless they submit a detailed justification. The thresholds and resulting justifications cause delay or cancellation of provider orders and place a heavy burden on public health staff to justify vaccine need on a weekly basis. We share the goal of reducing waste, but the thresholds and overestimation of inventory at the federal level are limiting operations and the ability to meet demand for vaccine. We look forward to continuing to work with the White House and HHS leadership and the Countermeasures Acceleration Group and CDC to resolve this issue. Thank you for the opportunity to make comments today.
Thank you for your comment. Our last public commenter for today is Dr. David Weissman.
Hello. Hello, can you hear me?
We can, please go ahead.
Thank you, Dr. Lee. The concluding comments at the last meeting advocated for transparency and expression of diverse views. I wrote a letter to you then and await the pleasure of your reply. I have submitted additional comments. Given the circumstances of this meeting, concerns about opacity are deepened. Having only now seen the presentations, in particular, Dr. Oliver's, which was only posted around the time she began, I'm simply shocked. I'm not a fan of any of the COVID vaccines, but my old employer and sometime client, I believe, is a vehicle here of regulatory misdirection. You are simply asking the wrong question. Our own analyses suggest a limited window of all-cause mortality benefit of these vaccines, outside of which, at both ends, there appear to be significant detriments. Although TTS is important, there are unexplained safety signals for all vaccines far stronger, including discoagulation, death, and myocardial infarction. We submitted this weeks ago to FDA and CDC at various meetings. According to the founder of BioNTech, the DNA-based vaccines may carry a risk of insertional mutagenesis. Also critical is that some key Pfizer and Janssen analyses have not been verified by FDA. That goes also for molnupiravir. How can you make any decisions based on that? In addition to reevaluating the use of all vaccines, you must consider estimates of VE reduction against Omicron to 30 to 48%, toxicity of cumulative dosing, reduced benefit for greater risk. Attempting to boost our way out of new variants is the immunological equivalent of heroin addiction. What is the subclinical risk of TTS or other dyscoagulation? These drugs are not classical vaccines, but gene therapy drugs. Are you concerned that CDC is not accurately representing the nature of these vaccines, depriving Americans of fully informed consent? Now to children, additional concerns other than the unverified data and the flawed risk-benefit analysis, which is off by 26 times in the wrong direction with at least a 4-time risk over benefit. Pfizer have changed their formulation for everyone, and it differs from the one that was used in the clinical study. The change may improve stability and increase effective dose, worsening the safety profile. The change may also affect distribution of the lipid nanoparticles, thereby affecting safety and efficacy. The use of Pfizer's drug in children is akin to using a car seat with poor regulatory oversight. The eyes of the world are on you. Your decisions are being mirrored in other countries. Millions are subject to mandates and other harsh measures, including imprisonment and loss of employment. The opacity here deepens mistrust within America and reverberates globally. Would ACIP want to be responsible for long-term detriments as well as unjust imprisonment based on reliance on flawed data? So in the spirit of transparency and diverse views, I'm happy to take questions now or later. Thank you.
Thank you for your comment. I want to thank our public comment speakers for joining us today, and the committee will now move on to discussion and a vote. Dr. Oliver, would you please be willing to put up the proposed language for the vote? And you can let me know if you'd like to also share additional slides if there's any clarifications around this. Would you be willing to take a read through it, please, for us?
Absolutely. So I can provide a few clarifying things. So the language that we have put up for a vote says mRNA COVID-19 vaccines are preferred over the Janssen COVID-19 vaccine for the prevention of COVID-19 for those 18 years of age and over. I can clarify that in the guidance that would accompany this clarifies that this includes vaccines administered as a part of the primary series and a part as a booster dose. And then I also want to clarify, because there'd been a question around, we specifically say for persons with a contraindication to mRNA COVID-19 vaccines. I can clarify that the only firm contraindication is those with a severe allergic reaction around a previous dose or a component of the mRNA vaccine. So that's the contraindication that is listed in the FDA EUA. Then we have some additional guidance around a precaution for those who had myocarditis after a first dose around getting a second dose of an mRNA vaccine, and that's all included on the clinical considerations website. But just wanted to provide that if that's additional context and helpful for discussion. Thanks, Dr. Lee.
Thank you so much, Dr. Oliver. I'll ask if there are any questions, clarifications, or further discussion points that ACIP members would like to make at this time. Dr. Brooks.
Yes, when we vote, we'll also be voting on the guidance. First, for clarification, that is correct, right?
Typically, we will vote on the language that is posted up on this slide, and the clinical guidance would follow based on the conversation we have during this meeting. But I'll, again, look to Dr. Oliver to clarify that.
Absolutely correct. We have our clinical guidance team in the room making adjustments based on the discussion, so can confirm that we're actively updating. You don't specifically vote on the guidance, but we make sure it reflects the ACIP discussion.
Thank you. Ms. McNally. Sorry, go ahead, Dr. Brooks. One more question.
I just said, thanks for that clarification, because I believe that the guidance is crucial. And so I just want to be sure that the guidance reflects the perspective of the committee.
Agreed. Thank you so much, Dr. Brooks. And I know Dr. Oliver and team will make sure that the comments are integrated. Ms. McNally.
I have two questions. The first is for Dr. Mary Rubin regarding a status on the vaccine injury table for the countermeasure injury compensation program.
Hi, Ms. McNally. Thank you for that question. At this moment, CICP has not yet developed or published a countermeasures injury table for COVID-19 countermeasures. But pending establishment of COVID-19 countermeasures injury table, claims are still filed as non-table injuries, and eligibility of compensation will be determined on a case-by-case basis. That's currently what we're doing.
So I appreciate that very much, but I do want to encourage the acceleration of the development of that table for the reason that we now have the TTS issue as well as the myocarditis issue.
Thank you. I appreciate that. I did want to remind folks that we also cover other COVID-19 countermeasures outside of COVID-19 vaccines. So the table will also include that. But yes, we will take that into account, and we are discussing internally.
Thank you. My second question relates to implementation of a preferential recommendation in pharmacies, and I'm wondering if someone would be able to address how pharmacies will deal with this. Thank you.
We have Mitch Rotholtz on the line. Do we have anyone representing APHA on the line? Okay, perhaps we'll come back to that and we'll ask if our colleague is able to comment or speak up in a moment. Thank you, Ms. McNally. Is there anything else?
At this time, thank you, Dr. Lee.
Okay. Thank you. Dr. Paling.
Yes, thank you, Dr. Lee. I've been thinking a lot about the conversation we have had, and one of the points that I've taken from my colleagues is the importance of very clear and strongly wording of what we're about to vote on. And with that concept in mind, I'm wondering if the ending of this potential vote should be for all greater than 18 years of age without a contraindication, to make it crystal clear, and open to other people's suggestions. Thank you.
Sorry, I might have missed that. Dr. Bale, could you read what you would like for the vote language, just so I can compare it to what was just on the screen?
Okay, I like the first two lines, and I'm thinking about ending with for all 18 years of age and older without a contraindication.
Without a contraindication, okay. Dr. Oliver, I'm going to go back to our Dr. Wharton and Dr. McNeil, Dr. Cohn. It's not typical for our language to include a comment about contraindication. Usually that's included in other parts of the recommendation. I just want to clarify, is that something that would be consistent with prior recommendations?
This is Melinda Wharton. That is not usually how votes are written, and we, of course, generally are not making recommendations for use of vaccine in populations whom they're contraindicated. That's not something that we do. So I think it's actually implicit in making a recommendation that it's in those persons for whom it's not contraindicated. But Dr. Oliver reminds me it will be explicit in the guidance.
Okay. Would that be acceptable, Dr. Paley?
Yes, I wonder if we could just change, instead of for those, for all over 18.
Or for individuals 18 years of age and older, something like that? Yeah, okay. Okay. Dr. Sanchez.
So I guess implicit with this vote is that we as a committee recommend that this vaccine should still be available. And then second of all, from the others' discussions, I understand that there are and should be rare circumstances that the Janssen COVID-19 vaccine be made available. So I understand that availability or whether it's individual preference or contraindication to the messenger RNA vaccines. But then in those circumstances, then availability of this vaccine for the present until maybe other vaccines are developed. Because I still remain very concerned about this vaccine. But I do think that the guidance is going to be critical, and it has to be we have to be very explicit as to the risks involved and that the individuals do know about it if we're going to move forward with this. Thanks.
Thank you so much. Dr. Talbot.
I'm struggling a little bit with the word preferred because I don't feel like it's strong enough. And I think this kind of goes along with what Dr. Paling was saying is how do you make this stronger? But I don't really have a good recommendation, which is not helpful, I know. But I think the word preferred, I mean, I prefer strawberry jelly over grape jelly, but I'll eat, it doesn't seem to me to be strong enough. I welcome anyone's advice.
This is Dr. Oliver. I guess I will say we were trying to model this after preferential recommendations that ACIP has done. Oh, the sound is out. Our sound? Okay. Hold on if people can hear me. Can people hear me?
Actually,
We can hear you.
we can hear you. Yeah, I can't hear anybody else. Oh, now I just heard somebody.
I think we need Dr. Talbot to repeat her question.
Yeah, I didn't hear Dr. Talbot's comments at all.
Good. Okay. Can you hear me now?
Okay. Now we can hear you. Okay.
I'm just really struggling with the word preferred. I think we need something stronger. I mean, I think if preferred is, I prefer strawberry jam over blueberry. So I don't have a good recommendation and would really appreciate anyone else's thoughts if they had a word that was a little bit stronger. Thank you.
Dr. Oliver, did you want to add something? I'll just add my own opinion to that afterwards.
Well, curious, would welcome other thoughts. I think what we were trying to do is mirror this after, preferential recommendations that ACIP has made previously. And so we could adjust the wording to say that, there is a preferential recommendation for mRNA vaccines over Janssen vaccine. I don't know if that's a nuance or if that gets at what you were saying for stronger, but the reason we went with preferred is more of the precedent for other ACIP recommendations.
Yeah, I was going to comment the same. I actually looked back at over prior preferential votes, and this is how it is worded, and how it's been implemented has clearly been aligned with the preferential recommendation language, but I'm open to either. Dr. Long would like to make a response, I believe. Can Dr. Long?
Yes, I might suggest something. This is different than most preferences. It's, one might work. This is much stronger. So how about this? mRNA-19 vaccines are recommended for all individuals 18 years of age and older in preference to Janssen COVID-19 vaccine. I think the word preferred is so casually used, but recommended in preference to is a little stronger in my English understanding.
Dr. Lee, this is Melinda Wharton. I really do appreciate the committee's hearing from the committee about their...
We can't quite hear you, Melinda.
I'm sorry. We really do appreciate hearing from the committee about the strength of recommendation that you want this to convey. I think we can convey that in how we talk about this recommendation, in the communications about this recommendation, and in the clinical guidance and implementation guidance that will accompany the recommendation. I I think we get the point you're trying to make. So if you're comfortable sort of accepting that point is made and moving on to the next step, I think that would help us get through this.
Dr. Daly?
Yeah, thanks so much. Yeah, Dr. Talbot, I don't think I have a solution. I mean, we could say strongly preferred. I think one distinguishing feature from prior preferential recommendations may be that in that case it more related to effectiveness than it did to safety. And I'm not sure if that's a fair statement, but I think it might be helpful, Dr. Oliver, if you have the clinical considerations that we could take a look at, other than either keeping the language as is or inserting strongly preferred. I don't have an additional sort of solution.
I'll let that comment sit for a second while Dr. Oliver, perhaps, I don't know if there's backup slides, but I'll call on Dr. Lair next.
I would actually recommend strongly preferred.
So I'm hearing a strongly preferred or a preferential recommendation, but having it be clear. Oh, here we go. Dr. Oliver, please go ahead.
I would just say, I think this is what was shown. This is what I have available to show on the screen right now. This is what was shown during the presentation. Just to clarify that we will absolutely emphasize how important education around the risk of these adverse events is. As it relates to vaccine decision making, the specific populations where we're talking about, and ultimately that these are a relatively kind of small and limited, those with contraindications, and those who otherwise would not elect to get a COVID vaccine, and emphasizing that barriers with a 2-dose regimen should not be a reason that a Janssen vaccine is offered, that we encourage, initiating a 2-dose vaccine in all situations. Again, we can, we're continuing to make updates and agree with what Dr. Wharton said. We absolutely hear the strength at which people would like this to be made. So I don't have new clinical guidance I can put up right now, but I can assure you that we're working on it and are happy to share the guidance with ACIP members before it's posted to make sure that it's appropriately conveying your intent.
Thank you. Okay, I'm going to take 2 more hands and then I'm going to ask for a motion. So Dr. Daly.
Sorry, I'll put my hand down.
Okay, Dr. Long.
Let's go. Can we go back to the slide about the guidance? The first, I'm going to object again to what I objected to before. This just says education is great. It doesn't say who's educating whom and whose responsibility it is. So, they have to say more in this first bit about it is the vaccinator's responsibility to assure that the patient is educated if they want to choose this vaccine. I mean, you don't have to tell everybody who says, fine, I'll take the mRNA vaccine. You don't have to tell them about the concerns about the Janssen vaccine. But that's too weak a statement, and it doesn't say who's responsible for what. And I don't get 3 compared with 2. Preference. I think 2 says what we intend. You're not going to give it to someone just because they say, I'll take the mRNA, but I like this Janssen vaccine because I'm only going to get 1 dose. Or I don't know why I would open that door for 3.
So thank you, Dr. Long. Okay, I'm going to ask if anyone wants to respond to that comment, but I also want to make sure we get to the vote. So Dr. Talbot?
Yes, I actually was hoping to go back to the vote and make a motion.
Okay.
But my motion was going to edit what's currently on the slide.
Okay, hold that thought. Ms. McNally?
Before we get to the vote, I am hoping that we can see the updated EUA fact sheet language, and I also would like to understand in the recommendations around this, on the guidance around this recommendation, if similar language is used. In other words, if there's a uniform process by which doctors or healthcare providers are being advised to discuss this potential rare outcome.
Okay. So it sounds like we need there's a request to get the EUA language up. I'm wondering if Dr. Fink could potentially respond to that, but hold that thought. I'm going to ask Dr. Brooks, do you have a clarifying question?
Well, yes, I think that we may be underestimating the strength of a statement of preference. In other words, there's a lot of discussion about preference isn't enough. We need to say strongly preferred a recommendation. It is not that common that the ACIP votes to prefer one vaccine over the other. That is not the nature of our deliberations in the past. So I think that this is a very strong statement. I'll just leave it at that.
Yeah, and I'll just chime in that I actually agree with that. Every single preferential recommendation we've had in the past has clearly had an impact in the way vaccines are used. So I anticipate the same would happen here. Dr. Paling?
May I make a motion?
Sure. I think Dr. Talbot requested to make a motion first. Can we put the vote back on the table? Oh, this is the EUA fact sheet.
This is yeah, Dr. Lee, apologies, was just trying to show, I don't have the full EUA fact sheet readily available. We did highlight this in Dr. Daly's talk. The main changes were the addition of the contraindication and updated, case information based on the new data. And if Dr. Fink wants to comment more around what FDA has said, but this was our summary initially of what the FDA updates were.
Hi, this is Doran Fink. So what's being shown here is language that was added to the fact sheet for vaccination providers. And in addition to the contraindication, new contraindication language, and new language about reported rates of TTS, which appears in the warning statement. The warning statement was also updated to include or to be more specific about the clinical case definition for TTS, and also to further specify that available evidence supports a causal relationship between TTS and this vaccine. And then additionally, there is the fact sheet for vaccine recipients and caregivers, which was revised to include with appropriate language for comprehension by the lay public, information about the reported rates of TTS and also fatality rates for TTS in the section about who should not get the vaccine, which also reflects the new contraindication in the fact sheet for healthcare providers. And those documents are both posted to the FDA website and are publicly available.
Thank you.
Dr. Lee, can we also see the CDC's educational materials on this issue?
I'm going to assume we don't have a slide on that quite handy for the moment. Since it is an implementation question, what I'd like to do, and I'm assuming actually it has to flow from this vote, I'm going to ask if the implementation team and the clinical considerations team can follow up on that because the education has to, this all happened in the last day. So unless there is an educational material I don't know about, and since prior to this vote, it would be great to know. I'm going to let the team work on that, and I apologize. We're in two different places today, so I can't have eyes on everything. I do want us to get to the vote. I'm actually going to force the committee to go back to the vote. I actually want to I'm going to actually make a strong recommendation, and I realize that's ironic. Here's the issue. Our recommendations are recommendations. It's not a strong recommendation or a weak recommendation. This is a preferential recommendation. I'm not sure it makes sense to add adjectives because it is what it is. And I don't think we want to imply that some of our recommendations are weaker and some are stronger. I think we just need to go with the wording at hand. And that would be my proposal. But Dr. Daly, since you are chair of this work group, I'm going to defer to you and ask you for sort of your final input on this language. And then I think we need to move forward.
Okay, yeah, thanks so much. Dr. Lee, you said my sentiments well. I think we want to make our intentions very, very clear. And if that's done through a preferential recommendation that then has strong language that backs it up in the clinical considerations, I'm certainly okay with that. I just want to make sure that we're as crystal clear in the communication of this as possible. And then you said it quite well. Over.
Okay, thank you, Dr. Daly. All right, so I'm going to go back to Dr. Talbot and see if you feel comfortable with that, or if you'd like to defer, and we can move on to the next hand.
I'm going to disagree, just because I feel like not everyone reads the clinical considerations. So how I would phrase it would be messenger RNA COVID-19 vaccines are strongly preferred over the Janssen vaccine for the prevention of COVID-19 for all 18 years of age. That's just how I would insert it. And that's what I would put up for a vote to start.
Okay. I am going to, okay. I'm going to pause for a second. And can I just ask that we take a 3-minute break? I just need to confer with our CDC colleagues and figure out how to move this forward. I, again, just want to say that everyone will come back at 34 minutes after the hour. We are going to put a motion on the table and make a vote because we need to move on. And I don't want to, I feel like we're getting bogged down in language at this point. So 34 minutes after the hour, we'll reconvene. Thank you.